So thank you for coming. My name is Rebecca Hoffmann Francis. I'm the Director of Clinical Innovation at Maine Behavioral Health Care.
Steve DiGiovanni, pediatrician, and then the Director of the Resident Teaching Clinics at Maine Medical Center.
Steve and I have been doing this work for, I was trying to think of how many years now we've been doing presentations together. 4 years. Yeah, wow, it's gone by quickly. Where we, and we'll get into the details of how it came about in just a bit, but just to say that we believe, obviously, that addressing adverse childhood experiences is critically important, especially with a topic such as preventing suicide or many other even physical illnesses, again, we'll talk about, or mental health issues, that getting upstream and preventing adverse childhood experiences is really some of the biggest bang for your buck in terms of quality of life and health. We came at this from really feeling like it was important to have a dyad of leadership between pediatrics and mental health. We also have, both of us have a history and a strong interest in public health as well, and so really when you bring those all three together, you see why it's important to address adverse childhood experiences, and that's really what we're going to be talking about today. I'm going to assume that most of you have heard of ACEs or adverse childhood experiences, but I'm going to give you the background anyway, so that we're all starting on the same sort of scaffolding of how we talk about this. I can tell you from the mental health world, for the past 10 years I've been working in the area of trauma and adverse childhood experiences, where we've collected our own data in Maine. At Maine Behavioral Health Care, we've been doing this work for a long time. We've been collecting data on the exposure of kids in Maine to trauma. And what I can tell you is that the kids in our data set in mental health, again, these kids are 100% exposed to trauma. They all have a trauma history. But in Maine, we have somewhat higher exposures than the average. The average in Maine and in the U.S. is really around 1 in 4 experience 2 or more adverse childhood experiences in their life. And when we say an adverse childhood experience, we don't mean a single incident, we mean a type of trauma. So let's say neglect and sexual abuse or physical abuse or something. So, and over 60% of children in the U.S. are exposed to violence sometime in their life. We also know that you don't have to physically experience violence or trauma, that you can see it or hear it and have similar impact. It's interesting, I just did, I was an expert witness on did expert testimony on a case in Presque Isle, and there was a judge up there who really had this strong belief that the children weren't exposed to the impact of domestic violence, and that they weren't physically abused, that because they saw it and heard it, they weren't impacted in the same way. And so that's just in Maine, that we still have to educate the world that that when kids hear it or see it, or even if they're in another room, or even if they're not home, but they know that mom is not safe, for example, that kids experience violence in the same way, sometimes even worse. And these are sort of our basic tenets, and that there are evidence-based trauma treatments that help kids. So in the mental health world, we know that there are trauma treatments that work. There are ways to prevent adverse childhood experiences, so either preventing them primarily, like stopping kids' exposure, or secondarily preventing the long-term effects. That we know that there are things that work, and there are very simple ways that we can change the way we interact with children that are exposed to ACEs that can have a very long-term impact on their lives. For those of you who haven't heard of the ACEs study, this was a very large study that was done at Kaiser Permanente. It was done as actually part of their health plan, and so this was primarily working middle-class working families that were part of Kaiser's their health plan. So just to get a picture of what the sort of clientele were. And really what it was an internist, Vince Folletti, who, has anybody heard Dr. Felitti speak. Yeah. And Rob Anda. Has anybody heard Rob Anda speak? He came here for Grand Rounds, was it February?
Yep.
Yeah. So they came together through Kaiser and the CDC, the federal CDC, to do this study where they looked at, they took a screener of certain adverse childhood experience. I can't remember, it was 10, was it 10, Steve, do you remember? And they asked adults what their childhood experience was. And then they correlated this to health impact. And so just in this, and this is 17,000 people, so it's a big data set that they looked at. In this these 17,000 cases, 28% had been physically abused as children, 21% had been sexually abused, and 11% had been psychologically abused. 17% had been emotionally neglected and 10% physically neglected. 27, so a quarter, had experienced some sort of substance abuse in their lives. About a quarter, also 23%, had separation or divorce. 17% had a parental mental illness in their lives. 13% had a battered mother or exposed to domestic violence. And 6% had some sort of criminal behavior. So we're talking about a large impact, right, of adverse childhood experiences. And I remember Rob Anda, when he came, he did Grand Rounds at Maine Med, and he said this, that he was an epidemiologist and he'd never seen such a strong correlation in his work between any two things, that we had never seen such a strong correlation between adverse childhood experiences and later health effects. And I'll show you you'll see one right after another graph that looks exactly the same. Go ahead. How are you? Good to see you.
I was just wondering, with the parental separation, do they include deaths, parental deaths, or is it really the separation?
So we're talking about 20, 30 years ago, so I think they primarily were looking at divorce.
Okay.
I can't remember how the exact question is.
Some things I've read do put parental death in, of course it is an adverse childhood experience, but
Right.
I didn't know if that was included in the...
I think they were primarily talking about divorce.
It
but
was
I
loss
can't-
of a parent.
Loss of a parent, is that, I can't remember how the question was asked.
Of some sort.
And the interesting thing was, and I'll just say this sort of as a side note for those of you that are in the field, the ACEs questions were, there's this often debate nowadays about the actual ACEs questions,
Right.
because, they're not, the wording of them, like a battered mother, sometimes the language triggers people, but we're talking about 20, 30 years ago, and so, to analyze the language, we have to sort of think back to how we would sort of have developed questions 20, 30 years ago. And certainly, when we talk about using a screener now, using an ACEs screener, we certainly think about language a little differently. So, and they will tell you that this was not meant to be a screener. It wasn't meant to screen for ACEs. It was meant to correlate experiences that an adult had experienced with, their health, their current health. And so they weren't using it as a screener back then. So, so this, as I was saying, so every graph will look very similar. As you experience more adverse childhood experiences, your risk for everything goes up, okay? So this first graph is developmental delay. This is by age 3. So we're talking about young kiddos, right, when their brains are developing, that as you see more ACEs, a higher risk for developmental delay. Chronic disease, so this is heart attack, stroke, COPD, and diabetes. The more adverse childhood more adverse childhood experiences that a child experiences, the higher their rate for heart attack, stroke, COPD, and diabetes. What are folks' thoughts on that, for those of you that have seen these graphs? And I'll show you more. Go ahead.
Well, I'm assuming there are other intermediate steps, like if people are smoking more cigarettes because more likely to smoke because of their trauma, that already puts them at risk for MI and stroke, and so like a lot of those behaviors probably are an intermediate step between there, and you would find things besides just smoking.
Sure. So coping skills that are maybe not as positive coping skills, potentially. Sure. Okay, so here we have we're seeing a similar pattern, right? In terms of the prevalence of adverse childhood experiences, 1, 2, 3, 4, and this, just for those of you who have trouble seeing the graph, blue is 0 ACEs, red is 1 ACE, green is 2, purple-ish, right, is 3, and the lighter blue is more than 4. So again, we're talking mood disorders is the first one, anxiety disorders, substance abuse, and impulse control. Again, the exact same graphs. And in mental health, we have we see it often that when you get to 4 or more ACEs is when it sort of tips into really, really high risk. When you get to more than 4, it really is, and we'll talk about this, but it's really imperative to screen for impact. That when kids have more than 4 adverse childhood experiences, you're seeing risk of all kinds of things. And so to really start to screen for PTSD is really important.
So because that's old data, it probably includes PTSD and under anxiety disorders.
Mm-hmm. Yes, it's,
Okay.
yeah, it's definitely DSM-4 data. And now this, again, so our topic today, percent attempting suicide, and again with the ACE score of 0 to 4, you have almost 20% difference in the increase in suicide attempts between 0 and 4 adverse childhood experiences. And as you saw in the first slide, 4 or more ACEs is really common. It's not, ACEs tend to cluster together, so we often see neglect, impaired caregiver, emotional abuse, and domestic violence clustered together. So you're not often seeing one adverse childhood experience by itself, you're seeing them cluster. So when you have one, you often have more. And again, the risk of suicide is much, much higher when kids experience even 3 or more ACEs. And so this was the pyramid that was really developed, adapted by Floyd and Anda, to show that you have exposure to adverse childhood experiences, and first you see emotional, social, and cognitive impairment, and then, as you mentioned, the adoption of health risk behaviors is sort of, people are tending to cope with their impairments through health risk behaviors, whether it's smoking, whether it's substance use, whatever it may be. Disability, disease, and social problems, and then early death. So really linking adverse childhood experiences from birth up to death. Steve, do you want to add anything to this?
I mean, I think
any of them?
the big issue here is that from a medical perspective, we'd love to come in under the purple one and spend a lot of money and not get great outcomes. So what we're trying to do for the health system is trying to hit, in the prevention around adverse childhood, and then trying to push down the amount of social, cognitive, and all impairment, and then the next, trying to go up, reverse the kind of pyramid and how we approach it. And happily, so far, you'll see the health system has actually is paying attention to this, which is a big victory for us.
Absolutely. Yeah, and the earlier, obviously, that you impact the pyramid, the more chance you have of reversing also, right? So when you're giving better coping skills in here, you're not going to have the adoption of health risk behaviors, right? And in one of our projects, we're spending a lot of time with social emotional learning in the Portland schools. And we've gone to over 100 classrooms to bring a curriculum in, a social emotional curriculum for kids from early Head Start straight through, and they've even adapted the program for high school, because kids aren't necessarily learning, they're not learning how to have healthy relationships, right? They're not learning it at home, and they're not necessarily learning it elsewhere. So we have brought a curriculum in to help learn how to have healthy relationships, how to experience the range of emotions and express how you feel. And so kids aren't learning that, that fighting is the way, or violence is the way that they get their needs met, right? They're learning other ways. Go ahead. Do you want to ask?
What is the curriculum that you use in the
second step is the curriculum. That's what it's called, is an evidence-based social emotional curriculum. Okay, so what is the cost to do nothing? This is probably not easy to see for Michelle in the background, but I won't quiz you on it. Really what we're talking, what this shows is it sort of puts a number behind what the cost is when we don't address maltreatment is the slide here. And really it's incredibly expensive, obviously, when you're addressing the top of the pyramid. As Steve said, it's really expensive to to have an adult with, let's say, some sort of a medical issue that's hard to diagnose or hard to treat, and you are doing lots of tests, or even with kids, Steve will tell you, to have a lot of medical tests when you're trying to figure out what, let's say, a stomach issue is, when it's actually anxiety and, issues related to trauma rather than issues related to a stomach issue. But also, we kind of have this term that we talk about, which is we used to say the school to prison pipeline, which is really this idea that when kids have an adverse childhood experience and they don't get the support they need, it really sends them from school where they're not getting support. Let's say they are fighting and they get suspended, and then they go into JJ, to juvenile justice, and then they head into prison. That it's a very expensive pipeline, that there's very few ways out. And now they're starting to talk about the crib to prison pipeline, that it's actually early childhood, where if you don't intervene early, then you really have this pipeline, and to JJ, again, juvenile justice, and then to jail. And actually, there's a lot of studies that are showing now that kids are getting expelled from preschool at the same rates that they're getting expelled from high school. So kids are getting expelled from early childhood for behaviors that are behaviors as a result of, again, them not being able to deal with some of their challenges and emotional issues at home, such as biting or other issues like that. And early childhood is not really able to address them in the way that they need to be addressed without the right supports. And then those kids get expelled, and then they're in their home environment more, which often can be the very environment that's causing them stress. Do you want to add anything to this? Because this is usually your...
No, that was good.
No?
I can take that.
You want to do this? Okay.
Sure. So I kind of mentioned earlier, what we've done a lot of work on together and with our team is advocating across the health system. Maine Medical Center, MaineHealth is a big health system, so it requires multiple presentations in areas to get them on annual implementation plans, strategic plans, and things along those lines. So we have some really nice alignment right now, in that we are on MaineHealth's pediatric service line, we're on MMC's annual implementation plan, and we're the MMP primary care transformation project. So trying to align kind of the big three players there, and then picking similar metrics to move it forward. I won't go into the details there because we're going to talk about our projects and all in a little bit.
So where this all began, was a project that started at the city of Portland and Maine Behavioral Health Care, which was Portland Defending Childhood. This was a Department of Justice funded project, which was really, for us, most of our projects have been mental health funded. So Substance Abuse and Mental Health Services Administration was our primary funder, which is a mental health, it's the federal mental health entity. And this project, Portland Defending Childhood, was a demonstration project. So Department of Justice funded 8 sites around the country, and really what they were looking for is some transformation in terms of how do we address adverse childhood experiences. Portland was such a blessing to get this funding in Portland, because some of the other locations were Memphis, Boston, there were 2 tribal locations. It was bigger cities with a lot of community violence. And in Portland, we don't have as much community violence. There's this saying that we like to say that Portland is the safest city except in your home, or Maine's the safest state except in your home. What we have is domestic violence. That's our major type of violence that kids are exposed to. And so we kind of had a different issue here than a lot of the other sites, and we're a lot like a lot of other smaller cities or suburban, rural areas that have different challenges in terms of resource availability. You know, we have all these resources in Portland, and then you step out to some of the smaller towns and there aren't as many resources. Or, you know, the police are really the only resource. And so, you know, there's different challenges. And so we felt really excited to embrace this issue of domestic violence primarily and look at how we better focus on kids. And so Portland Inventing Childhood was this partnership with the City of Portland, as I said, and Maine Behavioral Health Care. And the City of Portland had, at the time, and a lot of things have changed in Maine since 8 or so years ago, but they had a lot of home visiting running out of the City of Portland. And so one of our project goals was to better align the home visitors in the City of Portland with the pediatric practices and the pediatricians around Portland, so that we were creating better feedback loops between home visitors who were going to begin screening for adverse child experiences when they go into homes with new babies, and better those feedback loops with pediatricians to really look at what happens when the pediatricians know about a family's social situation or their domestic violence. How does that child get different care? And we came upon Steve, who became our absolute champion. He's an incredible pediatrician and also a lead for MaineHealth and Maine Medical Center, but really he'd done a lot of implementation projects across MaineHealth, like immunizations and asthma care. And so we began partnering with Steve and hence Maine Medical Center, and we were both in the MaineHealth family. And this synergism was just incredible to begin thinking about how better we can serve kids, and in a much broader sense. So what started out as this tiny little piece of our project, which was to increase these feedback loops, became this massive project where we really transformed the health system and are in the middle of a transformation of the health system that Steve just mentioned in like 3 seconds through that purple slide, is really that we began screening children across MaineHealth, which is approximately, I think it's 1 million people, are 1 million covered lives out of 1.3 million in Maine and 1 hospital in New Hampshire. But approximately, I think it's 70% of the kids in Maine or something are covered by MaineHealth. And so what we're talking about is that we began screening and implementing screening in our medical record for many of the kids in Maine, 11 of the counties in Maine. When you turn something on in EPIC, which is our medical record, you turn it on across the whole system. And so we began this transformation project where we began screening kids at every well child visit for trauma and ensuring that our mental health system, which was Maine Behavioral Health Care, had the evidence-based trauma treatments to serve kids. And so this became something very large and very transformative in our system.
Question?
Yes, go ahead.
I assume what you just said is the catchment area would contain 70% of Maine children.
Yeah.
Do you have any figure on what percentage of Maine kids actually do or otherwise don't get regular routine pediatric care?
That's a tough one. For the younger kids, yearly averages for a well child visit, usually around 70 to 80%. Teenagers drop significantly to 40 to 50%. Maine's coverage is pretty good. Most kids have access to a primary care physician. Some areas will be mostly family practice. The hardest ones is if you have many little family practice where they're not doing a lot of pediatrics. It's the biggest challenge because they have a lot of other stuff they're focusing on. But overall access is not a horrible problem. Worse outside of the bigger areas. But our bigger issue in Maine is, at least for me, is that the health systems aren't addressing the correct issues as much as just the access. And I'll talk about some systems type stuff when I get to that.
I work out in the Buxton Standish area.
Yeah, that's a,
And I'm at a middle school, and a lot of kids there can't, they have no idea if you even have a pediatrician.
Right.
If they do, they can't tell me his or her name.
yep. So Buck,
And they can't tell me the last time they were there.
that area, we still have kids who come from Buxton Standish to the PD clinic here. It is a low, it's an area that's, even though it's close, it's very underrepresented. So.
Yeah.
It's amazing what 40 minutes
Yeah,
this
true.
stuff does.
Yeah, and from the mental health system, it's the same challenge in terms of we get kids that come into Portland
There's
from that
nothing
area.
out
And
there.
it's- Yeah, I'm gonna let Steve, you get to, I'm gonna let you talk about this. Because
Okay.
we're gonna, just time-wise, I don't wanna.
Gotcha. So a lot of the first step was, this to me was kind of transformative from a pediatric practice. I've been practicing 9 years as a primary pediatrician in the community, and then a few years running the teaching clinics. And then as I dove into this data, I was like, oh, we've been missing the boat. And so pediatrics, had some of the greatest accomplishments probably in medicine. Think of immunizations and child health and nutrition and what's happened with, infancy and delivery, and so we did all these amazing things. And then we kind of just kept doing the same things. You're focusing on, I think there's some important safety stuff we focus on, immunizations, infection, but that wasn't the drivers of health problems anymore. Really, it became psychosocial mental health issues that are the biggest impacts on kids, and our system was not addressing that. The training systems weren't addressing it. So a lot of what we did from the beginning, I always like to come in at multiple angles. I think you can go out and train, which is important, but if you don't build some things for people to work with, it's going to rapidly fall off and nothing's going to move forward. So basically each year we've gone out and put things into Epic and also provided trainings at the same time and referral resources. So 2015 was in combination with Important Defending Childhood, and we tried to, and I'll show you what we did there with changing how we screen for violence in the pediatric setting. 2016, we used a new developmental screening tool that takes a holistic family approach, not just where the child is from developmental at this point. And in 2017, we went back looking at these two tools and doing interactive presentations and trying to get pediatricians to how do I talk about these issues in the household or in the office when you're here.
So are you doing this training with family doctors as well?
Yep, so that was one of the things I was excited about this program. This is on mostly Maine Medical Partners. The first year we went out and we did all the pediatric offices with 500 kids or more across the state. We just used that as a cutoff because we couldn't get everywhere, so that included a mix of family practice and pediatrics. The next two down were Maine Medical Partners, which was all our pediatric and family practice sites.
Could you explain about the survey of well-being and time?
Yeah, I'll get to that. It'll be fun.
Oh, you did? Okay.
So first thing we did, and this was just putting a foot in the door. There's no you go, here's the national guideline about what you do. They're starting to come out now. They did not exist at all. So just from experience, I knew our safety questions were worthless. We kept asking, do you feel safe? Do you feel safe? Never got anything. We know stuff is going on. So we tried to, so what we did was expand the safety question as broad as possible, every place you're touching, and then added a new question, the bad, sad, or scary question. See, what is that going to trigger? There was a little bit of research on it, not a lot. We used a big group to kind of vote and say, let's try it. Got approval from the legal people and the risk people of being med. That was fun, and then we went forward. At the same time, we said, okay, we're going to come in and train you and tell you what to do. This looks complex, but it's really not that bad. So what we'd like it to be done is handed out when they hit the door on a non-identified piece of paper or laminated that can be erased. Some practices are having the MAs ask it. That to me is not ideal. If there's no risk, you just do it the next well-child visit. If there is risk, the MA puts it in the computer, but also tells the provider, brings back the form. I don't want these being missed. The provider then, it's such a broad question, it might be nothing or it might be something significant. So the next step is have a conversation. If it is something significant, we put in a PTSD RI screener. Pediatricians have not been trained how to look at PTSD in kids. So this gave them a tool that they could start with, basically.
What is PTSD?
I'll show you that in the slide or two. And then basically determine safety. Do you want to monitor it yourself? Do you want to refer to Maine Behavioral Healthcare, who has incredible expertise and access? And then we also started having integrated clinicians in our offices, which was the key. We also have a secondary screener if you want to look and see what all the different ACEs are, who but we didn't push that too hard because we didn't think the system was ready. This is what it looks like, just so you know, epic, lovely, and also painful, but here's the questions. If those are positive, the PTSD-RI opens up and you can use it. It's not you don't have to use it. I didn't want to put these like hard stops and piss people off. This is what the PTSD-RI looks like. There's a younger child and an 8 and up. The 8 and up goes directly to the child. It's a nice screening tool. It takes minutes. In the residency program, frequently a resident will come out and be like, well, these things seem okay. And then you go back in and hand them this, and there's multiple issues and multiple symptomology that's there. We also made it so the scoring was right there because no one can remember how to score any of these things.
And just for those asking about it, the PTSD reaction index is a measure that we use to score for PTSD symptoms in mental health. This was a shortened screener that was developed from the PTSD-RI. So the longer version, I can't remember how many, 20 questions, 17, I think, 20. And this is just, these were the questions that had the most sensitivity out of the longer screener. So out of the longer symptom screener. So they use this as a quick.
There's a primary care gives a 20 question. It's not like a fly. Other things we did, we built in the well child visit. You get patient instructions every time, automatically printed. We worked with Portland Defending Childhood to put resiliency and preventative type language in every age group all the way through. And then we put in epic information if something did happen, what family members can do and what resources are. So those were also built. We like to look at what we did to see, is this going to make, this isn't high level research, but it's mostly kind of quality improvement, and say, is this making a difference? As you notice, this is a lot of red. So what's cool about Epic, I can get a lot of data rapidly. This is 5 practices over 6 months, 9 months, and 7,000 well child visits came through. 540 kids came up with positive risk. And of those 540, 92% was the sad, scary, or bad question. And so, and only 3% of the time by itself was the safety question positive. So basically showing maybe it's time for a question number 2 and change that one. Haven't done that yet. Next question for us was, okay, well, there's all these positives coming up. Well, I'll get to that in a second. We also then looked at how the questionnaire was delivered. And so the 2 practices, and the practices, there are differences in population some, but 2 practices were handing it out. 3 were asking it by the MAs in the middle of blood pressure, and do you smoke, and why are you here today? And you can see an immense difference, 3.4% positive to 11%. So the idea of handing it out or trying to get some level of confidentiality, these are hard questions to have rapid fire at you. We then looked into the charts of all of those, okay? So 540 with positive risk, 412 times the pediatrician actually documented what the trauma was, which I was pretty proud of them because we didn't force it in any way. It just was, hopefully you'll do it. And basically, of the major categories of trauma in the national database, there's like 13 major, we hit every one except for trafficking in that first 9 months. And so you might not be able to see it all up there, but there's extreme personal inner violence, homicide, kidnapping, physical assault, sexual assault, school violence, natural disaster, sexual abuse, homelessness, neglect, school bullying, domestic violence. Medical trauma was very common, impaired caregiver was very common, bereavement, and then separation. This was the one we were capturing previously. We would ask,
What is separation?
Like the parents are separated, that type of stuff. There's a pretty large other section, and of those, of all of them, only 23 that we, in our view, feel was really minor trauma. We just couldn't categorize it into that. A lot of it was like we were homeless and now we have a house, but still a lot of stress, or extended family members who had passed away, or there was trauma or homicide or domestic violence or drug abuse and extended family members. So, from my point of view, we're bringing up things that I don't feel were probably going to come up otherwise. We did do a quick chart review of 100 insert charts with negative answers or no risk, and really the only thing that was coming up was separation. So we felt like we were at least starting to capture some of this. We looked at the age. Really, there was a little bit of a bump in the 1 to 2 year old, but it happened across the age range. What do we do with this information? So, this is, I went into an office for 40 minutes or 30 minutes sometimes, so this is not a study. This is just, we're rolling it out across the big system and hoping. But of those 524, almost a quarter of them were referred, which still is a pretty large chunk. Significant numbers off-sites. Most of the practices didn't have a full behavioral health full-time clinician yet, so we didn't have as much on-site then. We only about 20% of the time did they complete the PTSD-RI. 20% of those were positive. If that was positive, 50% got referred. So it is a tool we're trying to educate and trying to get people to use more often. All right. That's kind of where we're at with that initial kind of roll through. Any questions on some of the attempts there? A lot of it is built around that integrated clinician. And that's where we've also been pushing and have a part of our team is the lead of MaineHealth integrated clinicians.
Just a comment. I'm a clinical social worker in the emergency and acute psychiatry, and it's so helpful to be able to read an epic record from a primary care provider. I do mainly adults, but I do some kids, and it's just so nice to see the problems recognized, where they referred or whatever. So it's a nice, starting point.
Yeah, information.
It's just great to be able to go into that and see if they did go to a provider.
Yep.
And, all that's just really, really helpful.
And when it comes back from the ER, we appreciate that information too.
Yeah.
All right. The next tool we went after is the Survey of Well-Being of Young Children, developed out at Tufts. It's a standard for pediatric practices. 3 times under the age of 3, use a standardized screening tool for development. This is the first one that doesn't just look at where the child is developmentally, but looks at some other areas. So here's where it has a section on developmental screening and/or autism. And then it looks at behavior and emotion and family and parenting kind of like stressors in the way the child-parent dyad is working out. And then it screens for not all, but a significant number of ACEs. Just to show you what it looks like, it's a front-back page. The language is at the appropriate level. The questions are short. There's your developmental milestones. This one I love. So it looks at kind of difficulty with change, irritability, and routine, which pretty much summarizes early childhood parenting and the difficulties most people have. We use a very quick referral to our behavioral health clinician for difficulties here and try to prevent kind of going down the wrong path in that parent-child dyad. Here's the family questions. The tobacco one we ask elsewhere, but then it goes through the 3 questions around substance abuse in the household or parents, a food insecurity question, a PHQ-2 for the parent, and then 2 questions around tension and or arguments, trying to start that kind of domestic violence. There's no, in PDS, we really haven't, don't have a very good way of screening that. They're sitting there with both parents. I'm not going to, you can imagine it's a challenge. So this is kind of like, let's put our foot in the door and see if we can start to move forward some on that. So that's the tool. It took some training. Each section has different scoring. We have scoring cards. We have different handouts we've used, and it's a big thing to roll across the whole system. And these are questions that our pediatricians were not asking. So we had to get approval and buy-in and approval and buy-in. Once again, so EPIC, I don't have the whole thing built in, but the provider gets to pretty much say if they need review or not for each section, because it's a screening tool, it's not diagnostic, so it's just highlighting it might be an issue. And then what do they want to do? Are they just going to follow up at a standard well-child visit? They're going to follow up themselves. They're going to use their integrated clinician. They're going to refer to child developmental services or maybe behavioral health care. We'd like to track things to say, hey, are we doing this? This is a rolling metric, so we're looking for the practices to increase like 6 to 10% a month, or mostly up into 30 to 40%. By 12 months, we expect the practices to be at 75 to 80% of the kids screened in the last year. It's nice, the system supports building these reports, and we had it on one of our performance measures for this past year. We then also wanted to do some chart review to see what we were picking up. It's kind of interesting, so, think about that sad, scary, bad question. Picked up a pretty good amount for one question. now have an entire back and front. And probably not picking up as much as we would like. So smaller numbers. This is when we just rolled it out the first 6 months. So with 544 patients, 30% screened positive, and of those, 25% were recommended for a follow-up. And it shouldn't be 100% of that follow-up because it's going to overshoot. It's overly sensitive, like any screening tool compared to its specificity. What we noticed is that there's probably some training that needs to happen in that our results compare to the validation studies, and some of the validation was done at some behavior and development clinics, so it would be different. But like for the pediatric symptom checklist, the preschool one, like that, there's something going on. I think we're under. My guess is it's being checked off as some concern to having a conversation, and they're saying doesn't need review instead of putting the actual score in. We also saw a lot of variation in each individual practice. That'd be hard to explain by the population. So for the baby pediatric symptom checklist, one practice is up at 17% having some a needs review, and another one's at 3%. So that's part of our retraining and going back. The family results we wanted to dive into because really it was how there's some prevention in the development and the symptom checks, but we also wanted to see if we can start to capture some ACEs. And I would say it's not doing what we would like. It's the weakest part of the SWIT. The other parts they validated very well and have some nice studies. For the family questions, they took a few validated tools and smushed them together, but not in this way, in this population. So I think that's kind of part of the problem. So of the 554, only 32 had marked needs review. You're supposed to scan it. We were able to find the actual survey 23 times. People we're still struggling with their accuracy. Really, the issue is that out of 544, only 12 came up positive on family question 1. And we know that's not true. We know there's food insecurity. We know there's domestic violence. We know there's substance abuse. So it's not that people are, people are lying. The tool is not getting to where we want to be. You can see just rates of referrals. Pediatricians are very comfortable for developmental delay to refer. This is an autism screen. They're very comfortable there. They're not as sure what to do sometimes with the behavioral stuff. Everybody's sending to child developmental services. My goal for our system is that these will be equal at some point. So 50% of child developmental services or close to 50% to our behavioral health clinician. Because I think getting them in early and really working on that family unit with the skill level they have makes a difference.
But that's also because, like you said, they're more comfortable with the behavior.
Oh yeah, this is all new.
And the milestones get sent to them.
So, I'm going to say this is my practice. We have an integrated behavioral health clinician. She's excellent. She's there. I can walk down the hall, even if she's in with someone, I can knock, and she'll come in, meet the family, and then we'll call, work it off, and set up follow-up. So we have a very low threshold. All right. So those are our first kind of 2 dives into it. I think in the big picture, this is something that now pediatric offices are aware of the ACEs study, they're aware of trauma-informed care, they're aware of the importance of this and what's available in the community in a different way than we were 3 years ago. Obviously, we're not where we need to completely be yet. This is our next step. So what we'd like to do is for MMP say, okay, we're going to put almost like a certificate out there. What does a trauma-informed practice mean to us? And so that each year you receive some sort of education for your staff. You follow our best practice workflows, meaning you hand out, you don't have the MA ask and the other practice workflows around referrals. We're creating actionable data reports so that anytime there's the kids who are positive on like the screens, you can see back for the last 3 months who they are, and we're setting up time for the teams to review those to make sure these kids aren't falling through the cracks. That you actually have an integrated behavioral health clinician, and we've worked to increase their skill level in trauma-informed care. And then we're saying, yes, please use the 2 that we have to at least 70% of the time is the metric that we set. We're also asking MaineHealth to update Epic so we can put all this data right into a tablet or MyChart at home. And so if there's a confidentiality level there, that's nice. It just disappears. It'll be scored automatically. it's a big win for the system if we can move towards this for all of our behavioral health screenings. All right. Oops. And so this is the final thing, say, let's transform our well child care to meet the needs of the families of today, not of the families 40 years ago.
And the graphic for that is, as Steve said, 40 years ago, there was a lot more medical care that needed to be provided at a well child visit. There was more the physician was doing, so the amount of time the physician spent with the family or with the child was looked like this. And there wasn't even behavioral health. But as of today, this is the amount of time that really is spent with a family where the medical provider is still spending the majority of the time. This is how we would like to flip it, as Steve describes it, flipping well child care on its head, where potentially we front load with behavioral health, because a lot of the issues that families are facing today, that we're all facing, are life stressors, right? And potentially behavioral health meets first with the family, does some of these screeners, talks with the family. I know when I had, when my kids were really young and I would go into my pediatrician with my list, the list was all these things that weren't necessarily something that a physician needed to help me with. It was, okay, how do I quiet my fussy baby? How do I get them to sleep? How do I deal with the stress of a baby that's not sleeping? All these things that behavioral health is really well trained to deal with. And potentially have that front load. So then there's a relationship with the behavioral health provider as well, so that when things get more difficult or there's a challenge for the family, that they have a relationship with someone that they can work with. And then to use data better. So potentially these families that have some level of risk, they shouldn't be a family that we see once a year in pediatrics. They should be coming in more often. We should be checking back in with them, especially if there's, they potentially screen somewhat positive, or you're wondering potentially if there's some risk for that family. Have a way to bring them back in more than once a year, so that you can lay eyes on the family, ask them how they're doing, develop a better relationship with them. For things like asthma, for example, we have all these great metrics, all this great data that doctors and providers use to track kids with asthma. We should be doing the same thing for kids with different risk, with the risk of, especially if you look at all that data for adverse childhood experiences and what potentially that means for a child when they grow up. Those are kids that we should be watching like a hawk, right? To make sure that they're doing better. So these are areas that, and Steve talked about some of these, that we really want to look further. So we have this great tool, the SWIC, that Tufts developed, and it's free. They want it to be used. We think that we need to adapt it to better screen for different types of ACEs. So we've been in discussions with Tufts and with the developers of the SWIC to look at potentially adopting some better trauma questions. So we want to look at potentially our 2-question trauma screen versus a much more comprehensive trauma screen. One is, that's sort of the tip of the spear, really, is the Center for Youth Wellness in San Francisco. I don't know if those of you have heard of Nadine Burke-Harris. She's like awesome, and she's a pediatrician that really has developed some wonderful tools to screen for ACEs and to treat kids with ACEs. And so that's a model, and she made that available recently. You can find it online, and it's much more comprehensive. And what she does, which is interesting, is she builds in the score. She has children screened for types of adverse childhood experiences, and then they come in with a score. And so this child is a 5, and she does it a little differently. I won't get into the details, but that means that they have an ACE score of 5, and we know right off the bat anything over 4 is high risk. And so no matter what, that child's going to get referred to behavioral health just based on their score, because of that ACEs data that we showed you, knowing that they're high risk for all these other things. And so it's a different model, and it's something we're curious about. We want to know how effectively and efficiently we're training people. We're doing all these different models of training. Right now we have an online module that we developed that's 40 minutes about, and so we have that, and then we have in-person trainings, and then we have really robust in-person trainings. And so what's the sweet spot for training where people are actually going to change their behavior and how they work with kids? I don't think anybody really knows that, but we'd really like to know. And so looking at the ACEs identification and the SWIT versus our 2-question screener, workflow comparison, so that, it's pretty impressive just in digging in some of these records that we found that one of these 2 questions is answered 92 or 90 something percent of the time. Right there we've revealed that there's a question that doesn't mean anything. It's not even working. And it's the one that we asked across MaineHealth that we've asked forever. Yeah. So we just uncovered this with our digging into the records, and so we want people to use the screener more, but we really want to make sure that what we're asking actually means something to patients. It actually changes the way that we treat them. And so, and that we want to ask about symptoms, because if kids aren't having symptoms, many kids have traumatic experiences with no symptoms. And so we don't want to go down the whole path with them if they're not experiencing symptoms. And then this whole dilemma, and this question comes up every time we do the training about how to ask with the parent present. It's a dilemma with kids in general, right? So we struggle with that across behavioral health in schools and pediatrics. How do you screen with the parent present? So one of the lessons learned for us is that we need alignment across a very large system to get this, to turn this ship. And we've done that. We worked really hard for alignment across our service lines, across our mental health, entities, across our pediatrics, across our medical. So we've done this presentation or variations of it many times to people that make decisions, and that's been really important. So pediatrics and behavioral health are kind of, we don't get the big bucks, right, in research money and anything, and you add psychiatry to that, and you add public health, it's all at the bottom of the barrel, the bottom of the totem pole. And so to prove that this is important has taken a lot of work. It's kind of the forgotten issue for a variety of reasons, and so we need to keep making it important, right? We need to keep showing that this is important to pay attention to. And that's a lesson learned for us, right? We have to continue to do that over and over again, and we have to be okay with that. And community alignment's also been really important for us. So the United Way of Greater Portland just identified trauma as one of its Thrive 2027 10-year goals. That's really exciting and really important. That means money is going to go toward it. It means businesses are going to pay attention to it. It's really exciting for us. You need grant funds. You need CPPC is another large community organization. It's a conglomeration of different organizations, but it's paying attention to this. We have the Maine Resiliency Building Network. There's all these different entities. Where now in Maine, again, it's the ship is sort of turning to focus on ACEs, and it's the right time and it's important. And we're a little bit behind other places that have been paying attention to it for longer, but we're also kind of the tip of the spear in terms of pediatrics is really starting to pay more attention to it. So I think it's this right time in the cosmos of doing this work, and that's been an important piece of the puzzle. And we have an interdisciplinary team, and that's been really important. Again, community involvement with involvement at the medical center and mental health. Our system is right for this right now, and we have a great team that meets very regularly and works on this all the time. And so that's everything. And we have 1 minute for questions. Go ahead.
I was at a training somewhere sometime in the last 10 years, and there was talk about trying to get clinics more integrated into the schools. Has there been any progress on that?
Okay.
I know Keene was trying to get something going.
Yeah, I think it's actually gone in the other direction a
state
little
has
bit
cut
because of the state.
The state has cut the funding for school-based clinics to the bone. Some of the hospital, like our hospital system supports in Greater Portland Community Health. So we have them in Portland, and some other towns have it, but it has not been, it needs support. It's not going to be a money-making type model. So if you don't have state support, as I said, our health system has stepped up and continues to support with free physician time and some money. But what happened last year has not been pleasant.
Yeah.
I was just curious because it solves instantly that problem of how to talk to kids without.
So
their parents in the room.
true, so true.
Yeah,
And
school-based
again,
health centers on law.
Yeah, 5
Fantastic.
years ago, they were much
Obviously
more robust, and now it's kind of a state funding was cut for, like, for nurse home visiting, and although that's on the table. but-
And is the SWIC only for the first 3 years?
You can use it up to age 5, so it's right up to.
Is there anything for older kids that's similar to that?
Not exactly to the SWIC. There are some things, and that's what down the line what we'd like to do. We combine for our adolescents substance abuse screening, depression, and the trauma on one form. So that's our kind of model at the moment.
Is that available?
Yeah, we have, all our stuff.
Yeah.
If you type in MaineHealth ACEs, we have a whole webpage that has all of our trainings, toolkits, handouts, everything's there.
There were some questions.
I was wondering if practices that are affiliated with the MMCPHO can participate in this program even if they're not official MaineHealth partner, Maine medical partners practices.
We've offered all of our tools, and when we have time, we'll go out and do trainings. A lot of it has been just, there's only so much bandwidth we have. So any practice that calls us up, we'll respond to, hook them up with the tools at least. If it's a time of year that we have people available, we'll gladly help, but sometimes just bandwidth, we can't get everywhere.
Can that help facilitate if somebody's not in an official Maine medical center of practice, getting referrals to behavioral health?
Oh,
These
yeah.
kids?
They want,
You
yeah.
guys-
Absolutely.
They train across the state.
Yes. And we
Completely.
work with providers that aren't MaineHealth providers all the time, so absolutely. And I'm happy to, if I learn where you're located, I can talk to you about resources and training and whatever you may need.
So we have a handout on our website for all the behavioral health clinicians who've been trained across the state of Maine in these treatments by Maine Behavioral Health Care, and then which practices also primary care have integrated clinicians, so that's also available.
We have one last question.
I was just wondering if we were going to have access to the PowerPoint to review.
Sure. Yeah. I don't know if they're making them available, but we're happy to make it available. Yeah, if you want to leave your card or something.
It's not like after the evaluation, send it out.
Oh, okay.
Once you do
Great.
your evaluation.
Great. Thanks, everyone.
Appreciate it.